It's the PCI complications and management sessions. But we have one presentation by Dr. Ramesh Adiraju.
At the outset, I'd like to thank Sushil and Srinivas to invite me to participate in this conference. It was quite an experience and I enjoyed it. Thought I'll part with an interesting scenario. There was a lot of presentations on TAVR, which is a controversial and evolving field, as you all know, across the globe. Interesting part of it, which people don't realize, as fashionable it is to put a transcatheter stent valve, about 60% of these patients who are referred for this are not candidates for several reasons. Aortic stenosis, as you know, is a protected illness. I think I'll go through the slides quickly because this is a video presentation, so I'm going to have to keep moving it. A significant percentage, as I said, are not candidates for various reasons. TAVR itself is not without complications. As we learn and do more of these procedures, we're also coming across more complications, especially heart block patients who develop new left bundle branch, especially have a higher mortality that we're finding. So at Renu CA Institute, which is a endovascular institute that I've established in 2005 in Philadelphia, we try to find alternate solutions using existing devices in a different way. That's what I practice. So in this situation, we try to come up with a different approach to manage these patients who are not candidates for TAVR or non-surgical patients with complex disease and comorbidity. This little brief physiodynamics of aortic valve, which makes it typically difficult to manage with balloon valvuloplasty, which has not very encouraging long-term outcomes in the history. It's because of its torsion forces that act. Based on this understanding and the complications associated with TAVR, based on this understanding, I attempted using peripheral cutting balloons. The largest available is an 8 millimeter balloon. So we used 2 peripheral cutting balloons. This also helps. They go through 8 French systems. So double cutting balloon allows us to have a safer vascular access, which is also a problem with TAVR, and try to do a valvuloplasty with the cutting balloon. Is what the approach we adopted. I've done about 27 cases to date over the last 5-6 years, and this is one of the similar cases that I want to share with you. An 88-year-old woman, critical aortic stenosis, complex history, multiple admissions for congestive heart failure, 3 to 5 months before she presented to several different hospitals. Finally, also the other aspect of this patient is she has a chronic left bundle branch block and calcified small diffusely diseased aorta, which makes her not a good candidate for TAVR. And she was obviously turned down for surgical approach also. She was actually at the University of Pennsylvania, where TAVR program is pretty active in Philadelphia, where I practice. She was then, at the request of a family friend who I know, was transferred on a ventilator in CHF to our institute for consideration of double cutting balloon valvuloplasty. Baseline hemodynamics or aortic valve area is 0.46. Mean gradient, peak gradient, mean gradient was around 50. LV systolic pressure was 214. systemic pressure was 133. There's a significant gradient. So obviously she was a really sick patient who could not come off the ventilator and was living in the ICU for 3 weeks. Here's her EKG, left middle branch. Nothing ischemic. Here's a pre-valvuloplasty hemodynamic tracing. That's our cath lab. I think I'll let the CD play from here. That's, as you can see, it's a diffusely calcified diffuse disease, distal aorta. She also has renal disease. Coronary anatomy was quickly assessed just to make sure, what we're up against. Right coronary, relatively disease-free. The approach we use is double cutting balloon valvuloplasty from both groin axes. We first do one wire, one balloon. If this is a critical valve, like for example, she was 0.4 valve area, initial cutting balloon will allow us to stabilize the hemodynamics so you have more time to work with her as we go along. So this is the wires I use are 18 wires. These are smaller, relatively small balloons, so they can be used in 8 French access, which decreases the vascular complication rate. Here's the first balloon going up. The key for this procedure is to make sure we have a good, nice pigtail curve for the wire tip, because these wires are angioplasty wires and can potentially perforate the apex. Has a double balloon from both sides, double cutting balloon. As you can see, the wires bounce around a lot. The biggest cutting balloon available in market, these are peripheral, used for peripheral indication, but we used it in the aortic situation. The biggest balloon available is 8 millimeters. Hopefully we will be able to convince some of the industry to make a bigger cutting balloon. Angioscore is actually coming up with one. It's in the process. I've actually had talks with them. But I think the scoring balloon is, these are the Boston Scientific balloons. They have a tri-leaflet straight blades, which I think are better than the scoring balloon for aortic valvuloplasty. We all typically do a distal final ascending aortogram just to make sure there's no dissections in there. That is one complication when you use large cutting balloons in aortic position, is to you have to be careful about aortic dissections. So her valve area post valvuloplasty was 0.8, mean gradient dropped by more than 50%, which is a good result. There is an equalization of pressures, ventricular, systemic pressures. Again, gradients came down. And she was actually, a few things we look at for concluding the procedure is a 50% drop in the gradient, fluoroscopic valve movement, which we look at, also assess for aortic insufficiency. The benefit of this procedure is a low profile access from both groins. It can be repeated if necessary. This patient was extubated in 48 hours with the stabilized renal function, actually because of improved hemodynamics, and was discharged home. Here's the post-valvuloplasty gradient tracing. This is her echo, and I just wanted to put this final slide. I'm not sure if you can read this well, but basically this is our experience. I put it in as an abstract, was published in 2012 at the Asia Pacific Summit in Hong Kong. With good outcomes, these valves, we've done to date about 27 of these cases. All of them, the valves stayed open and clinically asymptomatic for the minimum of 3 years. Some of them stayed open till 5 years. complication rate is relatively minimal compared to the other approaches. In fact, this lady, despite having left bundle branch block with double cutting balloon valvuloplasty, stayed without any heart block and didn't require a pacemaker. So that's how I believe the future, if we evolve with this approach, is to have a ICE-guided scoring valvuloplasty technique using newer cutting balloons that might come down the pipeline. Thank you for your attention. I could
Thank you,
take
Dr.
some
Ramesh.
questions.
Are there any questions from the audience?
Yeah, Dr. Adiraju, this way.
Okay.
Yeah, we've been seeing you the last couple of days doing a lot of atypical stuff in the US, and I must congratulate you for this presentation and for the rest of the stuff that you are doing. What I want to know is, in the land of FDA, how do you manage to do such off-label stuff? Do you take some sort of a special permission from them, or is it just go ahead and do it?
Well, the type of practice I have, like I said, in 2005, I established an institute called Revascularization by Novel Utilization of Devices, and I also do clinical autonomic research for diabetics. I've been in practice 22 years now. There's a group of cardiologists in the area. Some of them I practiced with. Since the institute has been established, I stay by myself because they don't want to associate with me. But whenever there is a case that doesn't have good other options, they refer them to me. So the kind of cases I do are complex ones where there's no other choice, usually, whether it's peripheral vascular or endovascular or cardiac. So the family and the patient has been prepped by the other cardiologists already as to no further option, which is well charted on the patient record. And I explain the procedure and I write it on the chart that this is a novel approach that we're trying to use to kind of get them out of the situation they're in. So that's how I get around. And over the years now, I've collected a lot of data. Like we have 27 cases of this. I presented some cases of Silverhawk atherectomy in the coronaries. We have about 200 or better series of that now over the last
So is it
years.
because you're in a research institute that you're able to do it, and if there was a standalone cardiologist who was not working in a research institute sort of a setup, can he go ahead and do this kind of a stuff there, or is it?
Not really. But, like I said, based on the local area, my understanding with the other cardiologists that have been in practice, I have a lot of experience with Silverhawk, for example, in peripheral vascular disease. Right from when Silverhawk was available in 2003, I had worked with John Simpson. In fact, we were trying to work with him on an IVIS-guided Silverhawk catheter and stuff like that. So I've been on TCT faculty right from '99 from time to time. So there is built some reputation so I could venture this. I'm actually an individual cardiologist. I'm not a university. They won't let me do this in a university.
Thank you so much, Dr. Ramesh.
Ramesh, I will ask you, what is the mortality in this, if you had, and how many had severe aortic regurgitation, if such a thing has occurred?
Fortunately, in the 27 cases we did, not one.
Okay.
Yeah. But like I said, if bigger balloons are developed down the pike and then you do cutting balloon valvuloplasty with a bigger balloon, I will have to be careful. The technique is what is important.
Yeah, now could you quantify the cuts that are given in the aortic valve by any of these techniques of
For lack
MR?
of time, I didn't go into the specifics of how to do this, but shaping the wire to have a secondary curve after the pigtail loop at the distal end of the wire allows the balloon to actually stabilize in the valve properly. There are techniques for that. And also to be careful while you dilate, you don't want to be over-aggressive. You want to be...
What I'm asking is, could you see the actual morphologic result? What has been done after the dilatation?
By echo, yes.
MR or CT or any of them?
No, we follow echoes. Echo
Okay.
and TE is the best way to assess the valve. The idea here is to try, in aortic stenosis, especially the senile aortic stenosis, there is circumferential fibers and there is commissural fusion. So we try to kind of rotate.
If somebody says this is the effect of mere dilatation, because we know that dilatation also occurs when you use two balloons of that size.
Right.
How do you say, no, it is not merely dilatation effect, it is something more than that?
The outcome, the long-term outcome of what we've seen, we know that balloon valvuloplasty has been used for years, and the outcomes of continued patency of the aortic valve after balloon valvuloplasty, including double balloon, is not that high. But in our series, these valves have stayed open almost 3 years. So and also we follow echoes where the valve opening can be seen. I actually have a 3D echo of a post-valvuloplasty case. We really don't have time to show this, but you can actually see the commissural splitting. One of the posterior leaflets are so calcified it didn't move, but the other two opened nicely. So we follow with TE or nowadays 3D CT echo, all those.